This is Christopher Sontag of UAMS Northwest Internal Medicine presenting a clinical vignette poster for the Arkansas chapter of the ACP. This poster is on a severe mucositis as a rare immune response to mycoplasma infection. My fellow co-authors, Jay Patolia, also of UAMS Northwest, and Dr. Kim Agee, pulmonologist at the Veterans Health System of the Ozarks, assisted in writing this poster. Mycoplasma pneumoniae is a common cause of atypical pneumonias and can present with a variety of extrapulmonary manifestations. Among these is a recently categorized immune reaction named Mycoplasma-induced Rash and Mucositis, or MIRM. This uncommon disease features orogenital ulceration, conjunctivitis, and typically minimal cutaneous involvement. Symptoms can mimic herpes outbreaks, Stevens-Johnson syndrome, and Behçet's disease. MIRM is rare in adults, leading to unfamiliarity with its management. Awareness of MIRM is important to correctly diagnose, counsel patients, and address dehydration, malnutrition, and pain through supportive care. For this case, a 34-year-old woman with history of anorexia presented to the ED after a failed trial of amoxicillin clavulanic acid for pneumonia with a dense left upper lobe consolidation on chest X-ray. The chest X-ray is located centrally on this poster. She also had fever to 103 degrees Fahrenheit, as well as generalized myalgias and arthralgias, and non-productive cough. Her initial labs showed a white blood cell count of 5.1, procalcitonin of only 0.05, and a CRP of 4.3 milligrams per deciliter. She was started on IV fluids and ceftriaxone and azithromycin. The patient subsequently developed oral ulceration and odynophagia, followed by painful vaginal ulceration, pseudomembranous conjunctivitis, and a lacy rash on her back and abdomen. Urine antigens, as well as blood and sputum cultures, were negative. Her CRP rose to 5.13 milligrams per deciliter. A chest CT showed possible left upper lobe cavitations. Skin biopsy showed exanthematous pustulosis. Autoimmune labs were negative, except for an ANA at 1 to 160 nucleolar. As her symptoms appeared to worsen, antibiotics were broadened to include doxycycline. A bronchoscopy showed diffuse inflammation. Lavage culture later was positive for mycoplasma, and the Mycoplasma IgM was 5,685. After 2 more days of extensive mucosal care, her symptoms abated. She did not require systemic steroids. With completion of treatment for her pneumonia, she gradually improved to baseline. MIRM is rare in adults and more common in male pediatric patients. Clinically, it features a mild rash with mucosal eruptions possible in oral sites, including lip, tongue, and buccal, as well as nasal, orbital, including conjunctival and corneal, urogenital, and anal membranes. Skin manifestations, when present, are varied. Acute phase reactants are usually elevated. Occasionally, a Mycoplasma IgM is present. Diagnostic criteria include less than 10% body surface area involvement, 2 or more mucosal sites, scattered skin lesions, and evidence of mycoplasma infection. Overall morbidity with MIRM is low, with a self-limited course linked to clearance of the underlying pneumonia. Supportive care is key. While steroids are frequently used, there is so far only anecdotal evidence of benefit. While the pathogenesis of MIRM is unknown, proposed mechanisms include infection-elicited immune response causing indirect tissue damage versus direct cytokine-mediated damage from bacteria present at the mucocutaneous sites. As here, an infection located in the lungs was linked to mucocutaneous disease, this case demonstrates that medicine is not just a collection of discrete specialties, and that an interdisciplinary approach to systemic illness is required to link seemingly unconnected symptoms. Thank you.